Good afternoon. I am Dr. Karen O'Connell. I am the Region 5 Pediatric Medical Director with MIEMSS, and I'm also a pediatric emergency medicine attending at Children's National in Washington, D.C. So this afternoon, we are going to discuss some pediatric trauma case reviews. I just wanted to let you know I have nothing to disclose. So our objectives today are going to be to review the impact of pediatric injuries related to recreational activities, especially since the summer's coming, describe unique pediatric characteristics that affect injury response and management. We're then going to discuss some of the identification and initial treatment priorities of major organ systems. And then last, we're going to look at some of the decision-making and triage and transport priorities for injured children. So trauma is the leading cause of death and disability in children worldwide. The most common injuries are actually different based on the age group. For infants, they are subject to physical abuse. Preschoolers who are adventurous and exploring the world often fall. And then school-age children and adolescents are more likely to be involved in a motor vehicle or pedestrian accident. So our first case is a 13-year-old boy who was previously healthy, fell while riding a new razor. He got it for his birthday. He was wearing a helmet and other protective gear, but he had no reported loss of consciousness. So I think we all remember when the razor came about and then the hoverboard. My sister-in-law got my children 2 of them, and so I am well aware of what the hoverboard does. But this was a huge sensation and increased emergency department visits substantially. Most of these injuries are not life-threatening and involve more fractures of the arms and hands, but it's not uncommon to have a concussion or a traumatic brain injury associated with them. So then kids also have some high-risk behaviors, even though the means, like the scooter, is not that dangerous in and of itself. So when you're evaluating these children and you're called to the scene, your highest priority for all trauma patients is to identify life-threatening injuries and to deliver therapies in the priority according to ATLS. So ATLS focuses on a systematic approach to the airway, breathing, circulation, disability, and exposure. So as EMS provider, you are from basically across the room or wherever the child is, you're going to look and see what is your gestalt. How sick does a kid look? You're going to look at their overall appearance, their work of breathing, and their circulation. And then next is your hands-on assessment. So you arrive and you're evaluating this child. He's alert, awake, he's speaking clearly, he has equal clear breath sounds, he's warm and well perfused, his GCS is 15, and again, he's alert. And the only thing that's obvious on exam is a left forearm deformity, left flank abrasion, and left thigh abrasion. You obtain a set of vitals. He's a little tachycardic for age, but he also is reporting a lot of pain, and everything else is normal. So these are your priorities for this particular patient. Again, his airway is self-maintained. You do an extremity neurovascular evaluation, so you can report that at handoff. You obtain IV access if possible, and then you splint him for comfort and stability for transport. And then the next highest priority is pain control. So pain management in kids is super important for many different reasons. Pain increases ED and hospital length of stay. It also increases pain scores with subsequent visits. It has been associated with some post-traumatic stress disorder in children. And then with infants, it does affect brain wiring. So our priority here in Maryland is to open up your protocol. This is the pediatric pain protocol. And highlighted here, you can see there are categories of the management of pain that is considered a small amount of pain, and then there's a separate one that is for more severe, moderate to severe pain. You can see here, this is the FACES scale so that you can assess and the kids can actually point to how much pain they're in. And the goal is for us to have a reduction in their reported pain scale over the duration of the transport and into their ED visit. So for kids less than 2 years of age, the recommendations are to give acetaminophen. And then for those with moderate to severe pain, you can see highlighted here, there are additional options such as fentanyl, morphine, and ketamine. So how are we doing on a national level with pain control in the pre-hospital setting for pediatrics? So these 3 studies all report that we actually have a lot of room for growth. The study by Hennis in 2005 looked at 269 children, and of all of these children, only 3% with fractures and 9% with burns were treated for pain. The second study listed here by Isaac in 2008 shows, out of 696 children, 64% reported the pain and probably used and did use a pain scale score, but only 2% of them were given analgesia, and 12% were given some form of non-pharmacologic treatment, such as splinting or ice packs. The last study here is by Brown et al. In 2015. They looked at 1,368 children, and again, pain score is documented about a quarter of the time, but only 11% of those children received pain management. There's also disparities in who receives pain management in the pre-hospital setting and also the ED setting. This one study of pre-hospital pain management looked at the MIEMSS database over a 2-year period of time. This was both adults and children, and you can see there's a very large cohort of patients that had painful conditions such as fractures, burns, and penetrating trauma. Those that received pain management, well, if you are white, 22% of those patients received pain management, and only 9% of African Americans did. Pain administration or pain medicine administration also varies by child age, and you can see here children only received pain management about 15% of the time. This is another example of the disparities in receiving pain medicines if you are a child. So these are the categories, and you can see in this left-hand side, the really young children, age 0 to 3, very rarely received any pain management. So back to our case. So our young man by EMS received a dose of intranasal fentanyl, was splinted for pain control and comfort, and transported safely to the ED. In the emergency department, he did require additional IV doses of pain management to get him to x-ray. And you can see here, this is his forearm fracture. So he has both radius and ulna fractures that are angulated and displaced. So he did require orthopedic surgery consult and fracture reduction. He was casted and went home. So our second case, this is a previously healthy 4-year-old who is riding his little scooter downhill, crossed into a street, and was struck by a car. He was not wearing a helmet or other protective gear, and reported the neighbors saw that he was thrown about 10 feet. So when pediatric patients are struck by vehicles, there's a triad called Waddell's Triad of injuries that are commonly seen because of the actual size of children. So first they are struck in their abdominal area and their extremities, and then that causes their forehead to then hit usually the roof of the car or the hood of the car. And then when they're thrown backwards, they get a coup contra coup type of a head injury because of the brain moving, accelerating and decelerating within the skull. So when you're looking at these kids, again, we're just going to review and highlight some of the ATLS priorities here. So first is airway and cervical spine protection. So assess for patency, make sure that there's no blood, teeth, other things that might obstruct the airway. Remove any debris that you can do while safely protecting the cervical spine. If the child needs oxygen, please apply that accordingly. So breathing assessment, you need to make sure that they have good breath sounds bilaterally. If you do need to assist with ventilations, manually, you can do it with a bag valve mask. If you have a kid who has a significant traumatic brain injury, is altered, and you're not sure if they're breathing well enough on their own, end-tidal CO2 monitoring is a very important adjunct when it comes to assessing ventilations and adequacy of breathing. So we know from several studies that pre-hospital hypoxemia is very common, especially in trauma patients and those with traumatic brain injuries. Hypoxia worsens patient outcomes. In this one study, actually the first one by Cook et al., looked at 131 trauma patients. A third of the patients were hypoxic upon ED arrival, and of those, 16% of them were profoundly, meaning less than 75% oxygen saturation. So our goals are to arrive with adequate oxygen saturation, maintain ventilations with an end-tidal CO2 between 35 and 40. And at all costs, we really want to avoid hyperventilation. It's very common in children. We breathe at a rate too fast. And what that does is it actually decreases cerebral perfusion pressure because it causes vascular constriction. So how are we going to manage these patients' airway in the field and on the scene? So we know that endotracheal intubation in children requires specialized training, and our success rates, both in the hospital and in the pre-hospital setting, are much less and lower than they are in the adult intubations. We do know from several studies that I'll talk about in just a few minutes that endotracheal intubation in the pre-hospital field does not change patient outcomes. So our recommendations are to use non-invasive measures. You can use 100% oxygen or a non-rebreather and bag valve mask if needed, and definitely monitor en route. So these 3 studies looked at the pre-hospital intubation of pediatric patients. The first one, and the one that's most known, is by Marion Gashler Hill et al., and this was back in 2000. This was a pre-hospital randomized control trial looking at intubations versus bag valve masks for children who were less than 12 years of age, and this involved 2 large urban EMS systems in California. So they looked at 820 children and looked at outcomes, both survival and neurologic, good neurologic outcomes. And you can see there that there was no difference between bag valve mask or endotracheal intubation for survival or good neurologic outcomes. And both of these were statistically significant. The study by Cooper et al. In 2001 was a retrospective study that looked at bag valve mask versus intubation for children with traumatic brain injury. And this was a trauma data registry, and they evaluated 479 patients. And you can see here, there's no difference in mortality between the 2 airway intervention groups. The last study by DeRusso et al. From 2005 also looked at the National Trauma Registry, and they had a sample size of 1,930 patients. And what they looked at was mortality rates, and they resulted that the pre-hospital intubation cohort had a much higher overall mortality rate, and you can see an odds ratio of 14. So they were 14 times more likely to die if they were intubated in the pre-hospital setting. If it's just mild or no head injury at all, the odds ratio is only 5. But if you are a patient with severe traumatic brain injury, you still have a 12-fold chance of dying if you are intubated in the pre-hospital setting. So in the pediatric population, we still have a lot of studies to do. We are improving our means of airway management, but the current recommendations, well, first, there's very little standards for pediatric intubation training requirements for our paramedics. But the recent NAEMSP position statement did recommend having at least 1 blindly inserted airway device available, such as a supraglottic or extraglottic airway, and I'm going to talk about those in a few minutes. And then the current model clinical guidelines are to really start with less invasive measures, so bag valve mask, and if that's not effective and you can't get really good ventilation or oxygenation, then move to an extraglottic airway. And if there's too much leak or you're not getting the pressures that you need, then move on to intubation. So here are some of the devices that you should be familiar with. To the far left are the laryngo mask airways. So those are LMAs. And the LMA sits, at the little mask cuff sits there right at the glottic opening. You also may be familiar in the upper right with the King airway, which has a single port, but it does have both a means of occluding the posterior oropharynx, but also ventilate. You have the combi tube in the middle, and then in the lower left, you have your eye gels. So having one of these available is potentially life-saving. So there is experience with extraglottic or supraglottic airways in the pre-hospital setting, but for the pediatric world, there's very, very little data. So this one study by Ostermeyer, and this was from 2019. It was an observational study of fire-based EMS system in Texas. They looked at 265 children who were less than 16 years of age, and these were kids who needed to be or needed airway management for respiratory failure or cardiac arrest. And they looked at the 2 cohorts before and after they implemented an extraglottic airway protocol. The outcomes that they were looking at were the frequency of intubation attempts, the success rate for both cohorts, and then patient survival. The results that they did report were that there was an increased use of extraglottic airways by EMS that resulted in fewer intubations. So they were able to manage airways and ventilate and did not need to escalate to intubation. But the sample size was too small, and they did not have enough evidence to be able to make a comment on patient outcomes. So currently, we are the PEDART group is looking at the comparison in children between bag valve mask and epiglottic airways and intubation for trauma, cardiac, and respiratory arrest. All right, moving through this HTLS protocol now. We're going to move on to circulation. So it's really important to avoid hypotension in the pre-hospital setting. In kids, there are a lot of means to assess circulation: pulse, blood pressure, cap refill. And if there is a deficit in any of these areas, it would be important to place an IV or IO and restore the circulating volume with either normal saline or lactated ringers, or whole blood if it's within your protocols. So the primary survey, again, hypotension, it is an independent predictor of poor outcomes. So it needs to be avoided at all costs. One study by Pegula in 1993 showed that overall mortality was 61% with hypotension compared to 22% without. And then especially in the group with traumatic brain injury, the same risks applied. Another study showed that the predictors of poor neurologic outcome were also related to hypotension, especially hypotension in the first 24 hours, and also the absolute number of episodes where you became hypotensive and needed to be resuscitated. And lastly, life-threatening hemorrhage accounts for 40% of mortality worldwide. So there's an increasing focus on pre-hospital whole blood use as the #1 go-to fluid for resuscitation. So the pediatric formula for systolic blood pressure. So the minimum is 70 plus 2 times the age, but where you really want to be is in this good range, which is 90 plus 2 times the age. The problem with kids, though, is that they, first of all, they wiggle around. They're not going to be cooperative all the time with a blood pressure cuff. We expect places to have pediatric sizes of equipment, but sometimes that can be a pitfall if the cuff is too big or too small. And then kids have an unbelievable ability to compensate for blood loss. They can lose 30% of their blood volume before even dropping their blood pressure. So in cases like that, tachycardia is the most important indicator. And once they become hypotensive, you're already kind of behind the resuscitation curve. So in the pre-hospital setting, blood transfusion has been shown to be effective and safe in patients with hemorrhagic shock related to trauma. So this most recent systematic review looked at the effectiveness and safety of pre-hospital blood transfusion for hemorrhagic trauma patients. The results for that packed red cells plus plasma, so the combination of the two, which is basically equivalent to whole blood, showed a significant reduction in long-term mortality. So you can see the odds ratio there is 0.5, so it basically dropped mortality by half. However, the same findings were not found at 24-hour mortality mark. So, this study and several others have concluded that whole blood is a better option for trauma resuscitation than your crystalloids, such as normal saline and lactated ringers. All right, moving through to the D part of ATLS. This is disability, dexterous, and decon. The cerebral cortex is what's required to be intact for you to be able to have an awareness of your surroundings and to be alert. There are 2 different systems that we do use, the Glasgow Coma Scale score, or a more modified and simple called the AVPU, which is just 4 categories: alert, response to verbal, response to pain, or is unresponsive. These 2 groups have been shown to be equivalent for those that are super alert and awake and those that are super sick, so GCS less than 3. But the middle group is a little bit more nebulous. But we like to recommend some kind of neurologic communication when you do handoff and you call in before arrival in an emergency department. So the brainstem, we also look at that with pupillary response and motor activity. All right, so back to our patient. So from across the road, you're actually like approaching the child. His overall appearance is he's unresponsive. He's working hard, he's tachypnic, like shallow respirations, no retractions, and then you look at his skin and he's pale and mottled. So you're worried about a multi-system injury in this child who was struck by a car. So now you have your hands-on assessment. He's got a lot of secretions, but his trachea is midline. He has very poor shallow tidal volume, but his breath sounds are equal. He's pale, diaphoretic, cat refill is about 5 seconds. His GCS score is 5, but his pupils are symmetric but sluggish. He does have a forehead abrasion, left elbow deformity, left flank abrasion, and left thigh deformity. You obtain a set of vitals on him, and you can see that he is tachycardic and hypotensive for his age. So now you have to think, okay, how sick is this kid? This kid is obviously a multi-injured child, critically injured, has decompensated shock and evidence of traumatic brain injury, and a high priority for deterioration en route. So your management priorities in this child is going to be to monitor and make sure that he can ventilate appropriately for his age. Maintain his end-tidal CO2 in a range of 35 to 40. It's very important to avoid hyperventilation in this kid unless there's signs of increased intracranial pressure and impending herniation, which I'll talk about in just a few minutes. If the pupils become unequal or one dilated pupil or any signs of posturing, that would be an indication to temporarily hyperventilate. You would want to obtain an IV and IO access in this kid and fluid resuscitate with whole blood if that's available, or a crystalloid. So this child needs to go to a pediatric level 1 trauma center. And so your two options here are Children's National in DC and Johns Hopkins in Baltimore. So critical timing is important. So you have to decide air versus ground, do the math, add the numbers up based on traffic, time of transport, and get the kid to a trauma assessment as quickly as possible. So he was made a trauma stat, and he was very close by ground. So he arrived in the ER and was evaluated by the trauma team. They did a full assessment, and you can see here his injuries on head CT. He had an epidural hematoma there. He had multiple extremity deformities and fractures. He had an elbow fracture, tib-fib fracture. He ended up going emergently to the OR for this evacuation of the epidural bleed, but he did recover fully and was discharged home from the PICU after a 2-week stay. So pediatric head injury, it is the leading cause of death and disability in children, and it accounts for 150,000 injuries every year. 7,000 children die from head injuries, and even more are left with permanent disabilities. So 30 to 50% of children with severe traumatic brain injury die from the injury sustained during the trauma. And you can see here the majority of children receive head injuries from falls, and followed by motor vehicle and pedestrian accidents. So the pediatric cranium and body really make it prone to injury. You can see here in infancy in less than a year, the head is 25% of the actual body size, and that drastically decreases as you age into adulthood. So that head to body ratio is disproportionate. They have very thin cranial bones. Because that head is so big and up high, they have a higher fulcrum, and so their balance is off. So that higher center of gravity allows them to fall more easily. They have weaker neck muscles. They have an increased water-brain content, which allows the brain to move within the skull more freely. They also have very immature nerve myelization, and they're prone to that acceleration-deceleration injury called diffuse axonal injury. And then again, they have an increased metabolic rate. So once they have a traumatic brain injury, they're more prone to that secondary phase of injury. So head injury management also follows the ATLS guidelines. So most important is that life-threatening injuries, avoiding hypoxemia, avoiding hyper and hypoventilation, preventing hypotension, and monitoring for mental status changes. Our main goal here is to perfuse the brain. So your cerebral perfusion is dictated by your mean arterial pressure minus your intracranial pressure. So there's nothing you can do about the intracranial pressure in the pre-hospital setting urgently to fix that. It's already kind of fixed. But your mean arterial pressure, if you prevent hypotension, that's where it's going to make the biggest difference when perfusing the brain. And I've listed here some normal values for you to reference over time. Why do we worry about all this? Well, there's a lot going on in the brain, and there's a whole host of different herniation syndromes that you can see here in the character to the right. But clinically, and especially in the pre-hospital setting, what you do need to look out for is changes in mental status over time, more lethargy or agitation, that unilateral, blown, or unresponsive pupil, signs of posturing, either decorticate or decerebrate. And then the Cushing's triad that they talk about is really unreliable in children. It's rare to get the triad of hypertension, bradycardia, and that Kussmaul irregular respirations. But if you do see that, that is a warning sign of herniation. So what to do in the pre-hospital setting? Elevate the head of the stretcher at an angle of 30 degrees. Again, you want to keep, you want to maximize your cerebral perfusion pressure and decrease your intracranial pressure. So you want to normal ventilate, you want to sedate and provide pain medicines. In the ER setting, these patients often get intubated, and so the neuromuscular blockage will allow for less metabolic demands, and it also decreases intrathoracic pressure. And then seizure prophylaxis, a lot of these kids, blood is so irritating to the brain that they do need to have seizure medications to prevent them from consuming or increasing their metabolic needs. In the ER, we have worked hard over the last decade to decrease CT scan utilization. And I'm just going to go through this briefly, but this is an algorithm from a PECARN research network across the country. And this just looks at children, both less than 2 years of age and also 2 years of age, and walks you as a provider through a decision tree. So who needs to get a CT and who doesn't? So who's at high risk for clinically important traumatic brain injury and who's not? So it just plugs you through the clinical findings and symptoms to help you as a clinician make a decision. So the same, again, this is the algorithm for those who are older than 2 years of age, and we've made substantial improvements in unnecessary CT scan use. All right, so this is a subdural hematoma. So the subdural hematomas occur when a blood vessel near the surface of the brain bursts, and it's usually from tears in the bridging veins that cross the subdural space. And then the blood builds up between the dura mater, which is the covering over the brain, and the brain itself. This is an epidural hematoma. So this is occurs when the blood accumulates between the skull itself and then that lining, the dura mater. And this typically occurs when there's a skull fracture associated with it, and that tears an underlying vessel, and you get an accumulation of blood. This is the diffuse axonal injury that we had talked about. This is the shearing of the axons causing a lot of cerebral edema. You can see here you've lost the differentiation between the gray and white matter. You no longer see the little squiggly surface of the brain, and that's from the significant acceleration and deceleration movement within the skull. Okay, our third patient, this is a 14-year-old female, previously healthy, riding an ATV that flipped over when she hit an embankment. There was LOC at the scene. Bystanders were able to pull her from under the ATV, but she remained unconscious. So I do have disclosure. So as a physician, I don't recommend the riding of ATVs. However, I have ridden an ATV, and I know many people who ride ATVs. It's just do it safely and correctly. And here's how you're gonna teach people around you how to do it correctly. So we laugh that ATV is another trauma victim, but it's not a funny matter at all. These are designated for off-highway use, but they're often driven on the road. And we have recently had children who have been hit by cars on these. They range in weight. So some of these are 5, 6, 7 times the weight of the children who are riding them. And then they can travel at incredibly high speeds. So ATV injuries claim lives every single day. Every year, about 130 children die from ATV-related injuries. And of those, you can see 43% are less than 12 years of age. It accounts for 40,000 annual ED visits, a ton of serious injuries, and you can see the cost of medical care. So most ATV households, so people who own ATVs, live in rural areas, and the South and Midwest are the most prevalent areas that have ATVs and AT-related deaths. So these are the characteristics of children who are at risk. So male patients account for 60% of the deaths. If you are less than 16 years of age, 40% of all injuries are in that cohort, and 35% of all deaths are in children less than 16. If you do not have a lot of experience riding an ATV, so less than a year of riding or less than 25 hours each year of riding, If you pile the children on and you have multiple people, those are the ones that end up dying from ATV-related accidents. And then those who are riding larger vehicles. Again, you can see these kids are tiny. They probably weigh anywhere between 30 and 45 pounds, but they're riding a very large adult-sized ATV. So this truly is not a walk in the park. You can see here, it looks like a lot of fun, but it takes a lot of coordination to be able to maneuver an ATV safely. You have to have the right size, strength, again, coordination when you're going down embankments, navigating very steep hills and going around turns. Because these ATVs are often 2 or 3 or 4 times the size of the child who's riding them, when they are injured, it is a full body, full system complex of injuries. So you can see here, head, neck, torso, extremities, all are injured about the same proportion. So, you know, because of the dangers and the loss of life related to ATV use, several professional organizations have made statements about the public health hazards related to ATVs. In 2004, the American Academy of Pediatrics made a statement that children under 16 years of age should not be allowed to operate ATVs, regardless of the size. In 2005, the American College of Surgeons considered ATVs to be a significant public health risk. And then shortly thereafter, the American Academy of Orthopedic Surgeons also said that children under 16 usually don't have the perceptual or coordination to be able to manage and maneuver an ATV safely, and that children less than 12 years of age do not possess the body size or strength or motor skills to be able to safely handle an ATV. So back to our patient, again, 14-year-old female pulled from underneath an ATV. So her airway is patent, her trachea is midline. She is very tachypnic and has very shallow, rapid breathing, decreased breath sounds bilaterally. She is pale, diaphoretic, her pulses are thready, and her cap refill is about 4 seconds. She's awake, but a little confused. You give her a GCS of 13. Her pupils are symmetric and reactive. And then the injuries, when you take a good look from head to toe, she has a forehead abrasion, chest wall contusion, abdominal contusion, and some tenderness. Her set of vitals reveal that she is tachycardic with a pulse of 120, breathing at a rate of 36, which is much too fast for her at the age of 14, and she is normotensive. So your index of suspicion is that she probably has a major chest injury. She could have abdominal injuries. She has some signs of shock, and most likely it's hemorrhage because it's a trauma-related accident. She does have evidence of multiple injuries, some on her forehead, her chest, her abdomen, and she is at high risk for deterioration en route. So she has compensated shock. She's still normotensive, but she's tachycardic, and you're worried. So your management priorities in a kid like this is to oxygenate, give her 100% non-rebreather. If she's breathing well enough on her own. IV access is important because you're going to want to fluid resuscitate her because she's tachycardic and has signs of shock, poor perfusion. So whole blood or lactated ringers or normal saline, as we discussed earlier. And then again, frequent vital signs en route will help when communication needs to occur prior to arrival so that the receiving team can be prepared for a kid who's in hemorrhagic shock. So she needs to go to a level 1 pediatric trauma center. She's 14. And then you have to decide based on her injuries, whether or not to go by ground or air and the timing of transport. So thoracic injuries in children are not uncommon, especially in a case like this. Their anatomy in and of itself makes them more prone to serious injuries on the inside, even without any evidence of trauma externally. So their chest is very cartilaginous, very compliant. They have a very thin chest wall, so a lot of those forces get transmitted right to the internal organs. So you have to have a high index of suspicion based on the injury mechanism and the clinical findings on your exam. The most common injuries in the thorax are rib fractures and pulmonary contusions. The physical exam findings vary a lot with thoracic injury. Obviously there's a lot of pain involved as well, but these kids are often like tachypnic, tachycardic, hypoxic. They can become hypotensive with some of these very serious thoracic injuries. You may or may not hear clear breath sounds because of the wide transmission of sounds in the pediatric thorax, especially with the little kids. And then again, you may not have any external signs of injury, but significant internal ones. So some common injuries that occur in the thorax, especially with the ATV or rollover or crush injuries, are pulmonary contusions. So you can see here that's the red arrow is indicating a bruise of the lung or pulmonary contusion. Here, this patient to the far left has a pneumothorax with the arrow, but then also has a very wide cardiac sac. So this child also has a hemopericardium. So there's blood collection within the and around the heart. This puts this person at risk for tension pneumothorax physiology, where you don't get enough blood return, and so you don't get enough cardiac output. So this is a medical emergency. This is also a medical emergency. This is a tension pneumothorax, and you can see it's a full pneumothorax there with the red arrow, but the patient's physiology with shock components make you worried that there's tension component to this. This is another x-ray of somebody with a pulmonary contusion, but also with a hemothorax. And right where the head of the arrow is, there is a line that you can see of a blood collection. The problem with hemothoraces is that each hemithorax can hold 40% of circulating blood volume. So these kids can lose a lot of blood, and their only indication would be tachycardia. So you have to have a high index of suspicion for this. And then next, when you see a chest X-ray of the widened mediastinum like that, I would worry about major blood vessel rupture. So this is common again with rollovers and crush injuries. All right, abdominal injuries. You can see here the ATV again, twice the size of this person can cause a lot of abdominal injuries. So the pediatric body again, small. Greater forces per body surface area allow for injuries to occur internally more commonly than with adults. I don't know if anyone has a little toddler, but their big protuberant belly as they run around, well, that's like liver and spleen right there out in the open. There are lots of organs there, very close in proximity. So usually if you have one injury or one organ injured, you often have multiple ones. Their abdominal wall, again, they don't have a lot of musculature, so it's thin and not very protective to those underlying organs. And then their ribs are very elastic, so it doesn't provide a lot of protection for those underlying liver and spleen. So the most important thing that we need to remember when we're caring for kids like this is trending vitals. So their vital signs are super important. If they become more and more tachycardic en route, that is a sign that there is something going on, which is most likely blood loss. The pediatric blood volume is 80 mLs per kilo. So again, they don't have a whole lot of wiggle room, but tachycardia is the most useful indicator. This is just a formula. The cardiac output is equal to the heart rate times the stroke volume. And so children don't have a lot of means of increasing their stroke volume like adults do with vasoconstriction. And the way they compensate is with their heart rate. Some of the abdominal injuries that you will see, this here is a spleen injury. This is actually the most commonly injured intra-abdominal organ in the pediatric population. Most of these can be managed non-operatively, but if you have like a full fractured spleen and ongoing blood loss, a splenectomy in the OR may be indicated. This is a liver lac. You can see the blood there with the arrow that encases and goes all around the liver. There's also blood within the liver itself. So this is almost like a grade 4, fractured liver. Again, managed non-operatively, but some cases have to go to the OR for packing. But you can have significant morbidity and mortality related to liver lacerations. So our patient, this is back to her. So she was a trauma stat. As soon as she arrived in the ED, they obtained a chest, pelvis, and C-spine radiographs, which were all normal. She also had a head CT, which was normal as well. Her significant findings were on chest CT and abdominal CT. So her chest CT here, you can see that she has posterior pulmonary contusions. And then the one on the right, she's got a very large pneumothorax that ended up being a tension pneumothorax because she worsened over the course of her ED stay. Her abdominal CT showed a grade 3 liver laceration that was managed non-operatively. And again, in her ED course, she became more shocky, worsening respiratory distress. So she needed a needle decompression and then a chest tube to relieve that large tension pneumothorax, and then required blood transfusion. She was admitted to the hospital to the PICU and was discharged with minimal residual injuries. All right, this is our last case. This is case number 4. This is a 14-year-old boy, previously healthy, BMX bike racer, really talented, and fell while he was racing. Reports no LOC. He was wearing a helmet and all the protective gear that's required, but he is reporting to bystanders, and they communicate with you that he has some numbness of his arms and his legs. He just can't feel them. So non-fatal injuries related to motorbikes is on the rise. Yep, my neighbors have about 3 of them, so it is not uncommon. They do cause a lot of injuries in younger children now. People are putting their little kids on these bikes. 5% of major injuries involve children who are 4 to 7 years of age. So the injury types, like the body parts that are injured, are also very much like ATVs, but these vehicles don't weigh as much as the ATV. So you're going to see more extremity fractures and intracranial injuries, and less of the thorax and abdominal injuries that you see with ATVs. So your hands-on assessment now of this child is that his airway is maintained, his trachea is midline. He does have normal work of breathing and good breath sounds. He is well perfused. He's also alert and oriented, but is just complaining of neck pain and not able to move his legs or his arms as well as he wants to. He's trying to move them, but he has a very weak grasp. He's also reporting some numbness of his arms and his hands. He, on detailed exam of his extremities and his thorax, he doesn't have any other injuries that you note. You obtain a set of vitals. You can see here he's tachycardic, a little tachypnic, but he's normotensive. So cervical spine injuries. These obviously are devastating, but they're very infrequent, especially in the pediatric population. Studies have shown only about 1.6% of injuries involve the cervical spine in children. However, when they do occur, they are associated with a high mortality rate, especially when you're younger in age. 92% of cervical spine injuries are associated with traumatic brain injuries, so be on the lookout. If you have a major TBI, you have to assume they have cervical spine injuries. Most of these injuries occur in males, and the mean age is 10.5 years. And the mechanism of injury are usually high impact, high risk activities such as motor vehicle collisions or sports related injuries. Again, like everything else in the pediatric body, the anatomy of the spine makes it so that they are more prone to injury for many different reasons. So the spine in and of itself is very, it's an elastic column. Their neck muscle is underdeveloped, so they don't have as much control, both actively and passively. The ligaments are very flexible, as is the joint capsule. And so when you have acceleration and deceleration forces, they're more likely to have ligamentous injuries, especially when the facets, because they're flatter, they often will dislocate and then relocate. So even in this population, sometimes if you don't even have radiographic findings of a fracture, kids often tend to have what's called sclerosis, which is a spinal cord injury without radiographic evidence. So be really cautious and suspicious in kids who are having neurologic findings, like our patient, with numbness and tingling, even if the radiographs are ultimately negative. Because the kid's head sits so much higher up and is larger in their body, their fulcrum and their axis is a little higher. The younger the child is, the higher up your injuries are, because again, the head is so much bigger in the younger, compared to the rest of their body. So look for high injuries, C1 to C4 in little kids. These are the dislocations that we just talked about, the distractions and the relocations that involve cord injuries. The older patients, the older kids are often like adults, and they have more of the lower C5 and C6 injuries, and those are more spine fractures. So gone are the days, actually. I can honestly say that, where we would strap every child in and use everything possible for blocks to the heads. We are now more judicious and thoughtful, and who needs to have cervical spine protection versus immobilization. And a lot of our decision making and protocol changes have been driven by recent research and data. So just to define the two, spinal protection is the act of protecting the spinal cord from further injury, whereas spinal immobilization is the act of placing a patient on a backboard with a cervical collar for the purpose of trying to prevent excessive movement of the spinal column. So again, the PECARN network is a multi-site across the country network of hospitals that participate in research. The next phase has really been focused on pediatric pre-hospital research, and they have created an incredible infrastructure so that we could study some of the best practices for pre-hospital clinicians and patients. So this one study from 2015, this was Dr. Leonard and the PECARN Research Network. They looked at whether spinal immobilization in children causes harm. So they looked at 173 spine immobilized children and 112 children who were at risk for cervical spine injury but were not immobilized, and they compared the two groups. So out of these 285 children, only one had a C-spine injury, and that child was in the immobilized group. They also found that the children who were immobilized following trauma reported more pain and were much more likely to undergo radiographic evaluation of the cervical spine and be admitted to the hospital following trauma than children who were not immobilized, regardless of markers of injury severity. So through the research that has been done, we now have a decision algorithm and also decision-making tools to help us identify those children who have cervical spine injury and who are at high risk. So those that are at high risk are children who present with altered mental status, whether it's from a head injury, like we talked about, or intoxication. If any focal neurologic findings are concerning, the complaint of neck pain, torticollis, any other substantial injuries or predisposing conditions by history. And then diving, you can see here, that's a high risk activity related to cervical spine injuries and also high speed MBCs. So if the child has any of these criteria, the sensitivity of those 8 items is 98%, so they will pick up a cervical spine injury. But again, it's not very specific, so we have to really have a high index of suspicion. So Maryland protocols, this is on page 177 in the 2020 version. So there is a trauma spinal motion restriction algorithm. And I'm not going to walk you through the entire thing, but you can see here, there are high risk mechanisms of blunt trauma. And if a patient has any one of these following criteria, so cervical spine, thoracic or lumbar spine, tenderness or deformity, any neurologic findings, altered mental status, or very, very significant distracting injury, if they have any of those, and if they're younger than 15 with any of these, neck pain or torticollis, high impact mechanism, substantial torso injury, another predisposing condition. Sometimes our children with trisomy 21 have cervical spine abnormalities, so that would be an example. Or if you just can't really assess. So if any of those exist, then you actually move down to the cervical algorithm, and they guide you to put a collar on. And then it guides you down even further as to whether or not you need to do spinal immobilization or just spinal precautions. So reference this algorithm when you're trying to make a decision based on clinical findings and historical factors as to who actually needs to be immobilized versus spine precautions. So back to our case, again, this is the young man, 14-year-old with a cervical spine injury. So they, based on clinical exam findings and obviously his high impact mechanism, he received full spinal immobilization en route. He needed 100% non-rate breather. He became a little hypoxic and was a little tachypneic en route. He did have an IV placed and had normal saline or lactated ringers infused. And then again, in a kid like this, it's very important to look for deterioration en route, okay? Right now he has an isolated cervical spine injury, but he easily could have a developing traumatic brain injury and cerebral edema that can cause him to have altered mental status. So in a kid like this, he also needs to go to a level 1 pediatric trauma center, and your decision making is multifactorial and based on timing and severity of injury. So we decided based on this kid's clinical findings, and he was very far away from any of the 2 pediatric trauma centers. He had a medevac waiting for him, and he safely made it to the ER. He was a trauma stat and was evaluated by the trauma team upon arrival. His radiographs of chest, pelvis, and C-spine were all normal. His x-rays of his extremities were normal because he did have some pain and contusions. He had a CT scan of his C-spine, which was also normal. Because he was still having clinical findings of some neurologic deficits with sensory and motor, he did receive an MRI of the spine, which showed a small spinal cord area of edema. So there was a contusion there with some edema, but no active hemorrhage. So he did not need to go to the OR to have anything drained. He did receive IV steroids, which have been shown to improve neurologic outcomes in trauma patients. He was admitted for observation and was discharged a week later with no neurologic deficits. So he did very well. So thank you very much for being here today and for listening to this conversation about pediatric trauma. And the take-home message here is that prevention is the best medicine. So do what we can in our community and educate patients, families, and other providers about how to keep kids safe. Thank you.
California Casualty has been endorsed by the MSFA for 10 years for its auto, home, and renter's insurance. It is our honor and privilege to protect those who protect our communities. Happy 10-year anniversary to the members of MSFA. Thank you for all that you do. For more information about our program, please visit www.calcash.com/MSFA. We look forward to seeing you at various local, county, and state events.